Great. Thank you very much for inviting me to this great conference. Unfortunately, due to unexpected events in Israel, I cannot leave the country now because there's no flights. But hopefully next year I'll be attending in person. So thank you again for inviting me. And I will speak about mitral TEER tips and tricks in the yellow and red zone. I have 4 cases. Hopefully we'll have time for all of them. 2 of the cases are leaflet issues, and 2 of the cases are access issue, which is also a very interesting part of treating the valve, because you need to get into the valve sometimes when there is some issues to getting it. But let's start from the beginning. We know that TEER is considered for patients with severe MR. It is an established procedure suitable for both primary and secondary MR. We have the classic mitral A2P2 functional MR as a candidate for the secondary MR, and we also have the primary MR with prolapse of one of the leaflets. And we know that the procedure is suitable, and most patients will enjoy the benefit of a successful procedure. We also know that there is an anatomical differences between the mitral, which is directly related to your chances to get a good result. The classic green mitral valve is the A2P2 involvement with a mitral area of 4 with no calcification, with no significant flail gap. And as we go to the red area, the valve becomes more and more complex. And from the red and to yellow-red area, we always consider suggesting the patient a TMVR rather than a TIP. But we also know that most of the patients that are considered for an TMVR are excluded by different reasons, some of them anatomical, some of them others, anterior leaflets that need to do intervention in order to avoid LVOT obstruction. And we know that many of those patients remain without any treatment. So what is our ability to perform TEER in patients with complex valve disease? And I will present now 2 cases that might shed light on this issue. We know that in general, there is evolving indications for mitral TEER. We are far beyond the Everest criteria, and we are allowing us to do more and more TEER intervention in out-of-the-box indication, including complex anatomy. So the first case is a patient with DMR with flail of the entire posterior leaflet. This patient has several comorbidities, has a bypass surgery, has peripheral vascular disease, and he was hospitalized with heart failure several times. He was turned down from surgery. In all surgeons in Israel evaluated his cases and turned him down because of the anatomy. There's also some of the bypasses are crossing the chest, so they said that this patient is not a candidate for any surgery. So now we see the pre-procedural assessment. You can see here flail of the entire posterior leaflet, P1, P2, and P3, with multiple ruptured cord, which causing this disease of this patient. We see that the leaflets are big and allows us to use big devices, and allows us also to use multiple devices, because such a valve is rarely to develop any kind of stenosis. So we decided to start, and as we always do, if I think that I need multiple devices, I'm going first to the most medial part of the valve and putting the first device there. I must say that the grasping was a bit challenging because the valve was all moving, but I felt that after putting the first device, I will also stabilize the valve and make the other devices more easily grasping the leaflet. So this is the first clip. We put it on the most medial part of the valve. And of course, we can see that although the first clip is stable, there is still a lot of flail parts that are not affected by the first clip. So we decided to put an additional clip just close to the first one and then re-evaluate. This is the first one. And now we're putting the second clip close to the first one in the middle part of the valve around A2, P2. And we see that there is still, of course, flail of the lateral part of the valve, the P3 area, and we can see it here. And then we decide to add another one. So I decided to put the third one in the lateral aspect of the mitral valve, but make sure that I have enough place to add another device between the second and the third clip. So now we're grasping the lateral part of the valve. Grasping is easier, but still a bit of a challenge because of the movement of the prolapse part. And here we see this is the third clip, and you can appreciate that we have enough space between the second and the third clip to add another one if needed. And it needed, because all the valve was leaking, so we decided to put the fourth one between the second and the third one, and by that we clipped all the flail parts of this valve. It is highly important in patients that they have flail prolapse, flail parts, to grasp all the flail parts. Never leave untreated flail parts, because even if during the procedure it looks fine, the day after or a month later it will become severe MR. And here we can see the 4 clips, each are one beside that. All of them are symmetrical, in a good position, and this is the result of this TEER procedure. We put 4 devices. The severe MR decreased to a moderate, something like this, but the hemodynamics is very important. The V wave decreased from 50 to 15, and even more important sometimes, the pulmonic vein flow pattern. Sometimes it is more sensitive than the V wave. Especially when the V wave is around 20, 25 in patients with functional MR, look on the systolic vein flow pattern and improve it. This should be your target, because this is the real hemodynamic effect of this procedure. We didn't get any gradient, and we also gave the patient an electrical shock and restore the sinus rhythm with this patient. Now follow-up of 2 years, I think. Patient's feeling well, moderate MR, but no hospitalization. So this is the first case. Now go to the other side of the cases. Not huge prolapse, but other things. This is a 90-year-old woman presented with sudden pulmonary edema. This is her valve. We can see here, relatively small valve. We see a combined pathology of severe mitral regurgitation and moderate plus aortic stenosis, which is common among patients with severe MAC. We can see here severe MAC and rupture cord. On the patient who is not suitable for any other intervention, not for surgery and not for TMVR. We can see here the fluoro of the valve. We can see here complete ring of calcification with severe MAC. So this patient is not really suitable for anything. And because she has a ruptured cord, she's very symptomatic, because it is a kind of acute mitral regurgitation. So we decided to try and go for a clip on her. So you can see here the device going down, and one of the problems with the MAC patients that there is calcium between the area of the MAC and the leaflet. And sometimes it is difficult to get into the posterior part of the valve. So in those patients, you go down to the ventricle, go as anterior that you can, grasp the anterior leaflet, then go up. After you cross the MAC, then slowly go to the posterior area and do independent grasping of the posterior area of the valve, of the posterior leaflet of the valve. And we can see here that the first clip had a very good result, but still we had a residual flail middle to this clip. And as we said before, we never leave a residual flail. So we added another clip. And I must say that one of the challenges in these cases was the imaging. You cannot really appreciate the grasping area because of the shadow of the calcification of the MAC. Therefore, it is possible and it is advisable to do the grasping in the transgastric picture like we do in the tricuspid. In the transgastric, you can evaluate and see the leaflet without the interference of the MAC. So whenever you have a calcification, go to the transgastric and evaluate your gasping there. This is the final result. We can see 2 clips in severe MAC. The patient improved. The TEER in the MAC is a minimally invasive, suitable for frail, inoperable patients, and can provide symptomatic relief. The limitation, of course, is a gradient that sometimes is higher than the conventional TEER, and sometimes, of course, patients with concomitant MS cannot go for this procedure, and it sometimes can be a complex procedure with difficult imaging. Therefore, you should do it very carefully. So this is the second case. I have additional 2 that are not related to leaflet issues. The additional 2 are related to the way to the leaflet. So this is a patient, he's 60 years old, with paraplegia, and the previous history of non-ischemic dilated cardiomyopathy. In 2025 years ago, he had a mitral clip for severe mitral regurgitation. And we can see here that, sorry, it went here. So they put the first XTR, that was the device then. He had a good result, his V-wave decreased, but there was a significant right to left shunt that was occluded by Amphitheatre 14 in the same procedure. Unfortunately, in 2023, patients developed symptoms again, and he has recurrence of severe mitral regurgitation with a jet that is lateral to the first device. And when we evaluated this patient, we see that there is, of course, the ASD occluder in our way to get back to the left atrium. So what are the options of those patients? Maybe send him to surgery. We didn't want to send this guy for surgery because of his comorbidities. Therefore, we decided to try and go through the ASD occluder. However, we decided not to go in the middle of it because there is a lot of layers of the ASD occluder. We decided to go in the most posterior, most superior part of the LAD, of the ASD occluder. And the superior part, when you cross through the left part of the ASD occluder without crossing the entire ASD in the middle, which is difficult to cross. Then you need to dilate, and you don't really know if you can cross with the 24 French sheath of the mitral clip. So we're able to cross, see it, and then you can see in the right upper picture the angle of the delivery system. Because there is no movement in the septum, the delivery system is stuck in the septum. It is not very mobile. Therefore, you need to do special maneuvers that are not routinely done in the classic mitral clip procedure. We needed to use a lot of plus. We needed to gain height, and it was a challenging procedure to get the device into the mitral valve. However, we were able to do it, and we added another valve, another clip, just across the first one that was implanted a few years ago. We got an excellent result with systolic dominance in the pulmonic vein flow. And when you evaluate the ASD occluder after we crossed back, there is no any damage to the ASD occluder. The patient was fine, suggesting that sometimes the door is closed but is not locked. And you can definitely go back to an atrium that had an ASD occluder. And if I have additional 2 minutes, I will present the fourth case. Another issue of patients with an access issue rather than a leaflet issue. This patient had severe mitral regurgitation with occluded inferior vena cava. So we thought, what is the best way to go to this valve? Whether it's to go jugulary. The jugular, really, you need to do, it's very difficult to do the maneuvers with the delivery system. So we decided to go in a transhepatic access. It was a very good collaboration with our angio operator that really accessed the hepatic vein, and he put the wire in the inferior vena cava after going through the transhepatic. We can see here the crossing through the liver area, and we can see here the transeptal. You can see that the transeptal is not in the best location. However, because you come with a different angle, this is something that you need to take. You will not be able to manipulate the angle of the transeptal needle because of the different angle of crossing to the inferior vena cava. So you go a bit anterior, and there's nothing you can do about it. Therefore, you should use a lot of plus knob in order to get a better coaptation and better delivery system into the left atrium. But after you fix the aortic hugger with a plus, the other part of the procedure are relatively straightforward. We're able to put 2 clips and to get an excellent result in the end. And of course, in the end, systolic dominance, which, as I said, is the most important part of the procedure. And at the end, the angio came back, and we were pulling back the delivery system, and he put a coil closure to the hepatic vein, getting a very good and safe result with no bleeding. The patient 2 days later went home with a very good result. So our conclusions are that TEER remains the most versatile technique with wide applicable indications. Of course, more and more applications are being explored, and due to the high safety profile and the minimally invasive nature of the TEER procedure, we can definitely suggest this procedure for more and more patients. Of course, most of this data on these unique cases is based on case series and case report, and further prospective research is necessary to reach conclusions regarding those indications. Thank you very much.
Thank you very much, Dr. Shuvy, for showing us that one of the key aspects of a good interventional cardiologist is to improvise and find solutions to any problem that may arise. So it's a great cases, all 4 cases. Thank you for that. Any questions from the audience?
Also for the panelists, Dr. Koutsogiannis, Dimitriadis, Leontiadis, any comment?
Very nice talk. I would like to ask you specifically about organic MR. How do you see the future of mitral clip in this entity? Because of three reasons. First, the vast majority of patients have P2 rupture, which is easy to grasp. Second, many surgeries do not perform, even now, a good repair. And third, the goal may be more liberally to bring the severity down to moderate MR, because a moderate MR is acceptable for a good ventricle.
So I think that this is a great question about primary MR. We are getting better and better, and now we can definitely compete with the surgeons with the results of repair. And now there are two big randomized trials, the repair MR, and another trial that's evaluating mitral clip compared to repair with surgery. So I think that we are getting a very good result with the edge-to-edge repair. The issue that some of the surgeons always say that, okay, we put also a ring that is related for the long-term result and efficacy of the intervention. We don't know it yet. We don't know enough data to show if a ring is really required in our procedure, which is, of course, now we do not really combine it with ring. But I think that in the future, if we want to suggest those procedures also for young patients that can go for surgery, we should think also for the very long-term outcome, which means 8, 10 years. And in those cases, we might need additional devices, not only a TEER, but I hope that in next year we also have percutaneous ring implantation, and I think that in the future we might allow it might allow us to do combined intervention to the mitral valve, which will probably also allow us to get a very, very long-term outcome, which allows us to send to propose our procedure also for young patients with primary MR.
Okay, so, Dr. Dimitriadis.
Yes, another question from my side. Do you think it's a good strategy or a possible strategy to dilate an occluder, a septum occluder, if the sheath is getting stuck, especially in the case you saw already?
Yeah, there are some manipulations, but I think if you manipulate an ASD occluder, it is not really something that you can expect what will happen. So by doing our method, we tried not to get into the device itself, but definitely if you go through the device, you need to dilate with balloon, maybe do a gradual ballooning of the ASD occluder, and then go with the delivery system. Another thing that you cannot really know what will be after you take it out. Will the ASD occluder remain patent after you cross through it and ballooning it with 24 French device? So if you can avoid it and go in the upper part, just when the disc of the left side is there, it is, I think, a better approach.
Okay, so Dr. Leontiadis, the final comment.
Just on a question, before releasing the clip, when could you abort the procedure in terms of having an increase in the mean gradient on the valve?
Well, this is $1 million question. What is an acceptable gradient of a TEER? No one knows the answer. No one knows the answer. The cutoff of 5 is, I don't know, I don't use it. I must say that in many cases, I decided upon the hemodynamic aspect, which means if I decreased the LA pressure, the V wave, without increasing the mean LA pressure, which means the mean LA pressure is related to the mitral stenosis. So if I was able to decrease the V wave without increasing the mean LA, I go for it. Another thing that is important to realize, and we also published this, that there is important also for the gradient change compared to the beginning of the case, which means that if you started with a gradient of 1 and after the TEER you have a gradient of 6, I wouldn't live because it's too much. But if you started with a gradient of 4 and now you have a gradient of 6 and the LA pressure is good and the mean LA pressure is not going up and the V wave is down, the pulmonic vein is better, I live. I don't care about this 6. But it's very, it's related to the individual, the pathogenesis of the mitral disease, and also the baseline gradient. It is different if you start with a 1, and it's different if you start with a 4.
Okay, so we have to close the session. We enjoyed a panorama of mitral valve intervention.